Hello, my name is David Chandler, and I'm the Vice President here at GovernmentCIO. And now it's time for us to talk about mental health. The importance of mental health cannot be overstated. Over the past several years, the focus on this area has only increased. And with the COVID-19 pandemic, the awareness of the need for more expansive mental health care services has only skyrocketed. Telemental health services have played a vital role in helping to address this challenge, and we will discuss how technology, along with other methods, has been leveraged to provide mental health care services to those who need it. We have a great panel of experts here today that will discuss how they and organizations have addressed mental health challenges brought on by the COVID-19 pandemic. The experts and the organizations they represent have been focused on the availability of remote counseling during the pandemic. Let's meet our panel. We have Christina Armstrong. Christina is a clinical psychologist with the VA's Office of Connected Care. She supports the development of education and training programs for digital health applications throughout the VA. Dr. Armstrong also does research in clinical psychology, neuropsychology, and is an adjunct member of Pepperdine University's Graduate School of Education and Psychology. Welcome, Dr. Armstrong.
Thank you.
Next, we have Marquis Barefield. Marquis is the Assistant National Legislative Director for Disabled American Veterans. Marquis is an Army veteran serving from 1991 to 1998 as a combat engineer, as well as a military analyst. Marquis began his career with Disabled American Veterans in 1998 and was appointed in 2020 as the organization's Assistant National Legislative Director. Welcome, Marquis.
Thank you, and it's a pleasure to be a part of the panel today.
Absolutely. Dr. Jacob Warren is the Director of the Center for Rural Health and Health Disparities at Mercer University School of Medicine. Dr. Warren oversees partnerships with rural communities to engage in research and training and community outreach designed to generate novel, community-driven methods for eliminating health disparities. Thank you for joining the panel, Dr. Warren.
Thank you for having me and for focusing on such an important topic.
Absolutely. So we'll jump into the questions, and Dr. Armstrong, I'll begin with you. With your work in connected care at the VA, how has the COVID-19 pandemic impacted how you engage with VA stakeholders in the areas of mental health?
Thank you, David, for that important question. So at the where I work at the VA's central office, really, we had been working really hard on, making sure telehealth solutions, access to patient records through patient portals, and then also the development of mobile apps over the past decade. We've been working really hard on that for quite a long time. So it really was when the pandemic hit. It was an interesting thing for all of us who have been in this space for a long time, was everything we had been kind of pushing and researching and knowing that it was going to have a positive impact, but we were not seeing the adoption in the way that we would have liked. When the pandemic happened, the one, bright side of the pandemic was an immediate shift, this need to shift to virtual. We, of course, VA Central Office and all across the VA, we were ready for that in every single way. And so we really just shifted, and really our focus became, really implementation dissemination, making sure that all the VA staff were now up to speed, because a lot of them were kind of dragging their feet for a long time saying, this is new, this is hard. And it was at that point they realized we have to do it. So we really jumped at that opportunity to make sure everybody was trained up, and also make sure that all the veterans have access to all the equipment, resources they need to be able to access care in that way. So I think in that way, there was really a positive shift, because I would really love to see, even beyond the pandemic, for this access to virtual care, this ease for, especially our veterans in out in rural areas, that we just increase access to care in every single way. So I hope I answered that question.
Oh, you did, and it actually leads into a great segue. The next question is for you, Marquis. Your stakeholder community, disabled veterans, prior to the pandemic, faced a wide variety of challenges. Can you tell me a bit how the COVID-19 pandemic impacted your membership's ability to receive and continue mental health care services? And if and how telemedicine may have helped them to accomplish this?
Yeah, thank you for the question, David. First and foremost, I don't know if everyone knows or understands, but DAV is dedicated to a single purpose, and that is empowering veterans to live high quality lives with respect and dignity. And that when COVID-19 happened, 85% of veterans, to include our members, were going to VA medical centers or VA medical facilities, whether it be VA medical centers, community-based outpatient clinics, or vet centers at an 85% rate. And then when COVID-19 hit, the VA did a very good job of being able to switch to telehealth and virtual appointments as quickly as it could based on its systems. And now 80% of of veterans, to include our members, are now able to continue to receive their treatments, mental health appointments, regular primary care visits based on the ability that the VA was able to adjust very quickly to telehealth and even just old-fashioned telephone calls themselves to veterans to make sure that they didn't miss their appointments and that they didn't miss the needed care or treatment that was necessary for them. So we are here to support the VA's mission and support the VA's programs. That way, not only do our members, but all veterans are able to receive the needed care that's out there for them.
Great. Thank you, Marquis. Jacob, now to you. With your focus on health disparities in rural areas, another traditionally underserved communities, especially in regards to mental health services, what impact did the pandemic have on your ability to perform your work, and how did you need to adjust your mental health care approach during the pandemic?
It's a great question. It's a bit two-sided. I'll echo a bit of what Dr. Armstrong mentioned there have been a lot of advancements in the way we've been hoping to deliver care within rural areas that have come along with, quite frankly, policy changes that were instigated by the pandemic. And so things that previously served as barriers were removed. So for instance, there's of course, a national epidemic with opioid use disorder, and some of the provisions in care for what has to accompany medication-assisted treatment has changed with the pandemic to allow a more expansive view of, for instance, telehealth delivered counseling to allow for individuals to continue on MAT or MOUD. And so those policy changes have been very positive and have really opened up the floodgates for the changes we've wanted to see in rural for a long time. A lot of people don't realize how closely telehealth is tied to rural areas. With the federal advancement for the Office of Telehealth located within the Office of Rural Health Policy, it really shows how much telehealth can assist rural areas meet their healthcare needs, and in particular their mental health care needs. But at the same time, we've seen that expansion in opportunity to use technologies. The pandemic has highlighted some of the disparities that we know exist in access to technology. It has exacerbated social determinants of health that have in turn exacerbated mental health issues that we see in rural communities, particularly intersectional rural communities. So when we think about racial and ethnic minority residents of rural communities, now they have layering issues of equity that are coming into play. And so I think the general approach has had to be to embrace the policy changes, but recognize that their implementation isn't always equitable within rural areas, and looking at how we try to have additional access points, or to even go a little bit old school. So we all focus on smartphone apps and video conferencing, but some of the policy changes that have allowed for telephone delivered mental health sessions has been really critical in addressing some of those equity issues in rural areas, because an individual might not have access to broadband, or financially might not be able to afford video because the data is really expensive. And so being sure that we're preserving access to some of the lower tech solutions that are still technology based has helped to even out some of those equity issues.
That's a great response, and it sort of brings me to the next point I wanted to touch on. And Marquis, I'll kick it back to you for this one. You talked about access to technology, which leads us to the discussion of mental health services parity. Marquis, how have you been able to ensure that your care group has equity of access to mental health care services, and what are some of the strategies that you use to make sure that those services are provided?
Yes, when it comes to our membership, one of the things that we have done is we help spread the word that the VA was providing ways for veterans to still continue their mental health care during the course of this pandemic. And one of those things was the VA IT was able to ship out, laptops and smartphones to veterans in needed communities. From statistics that I saw or reviewed, there were like 16,000 laptops that were sent out and over 7,500 iPhones that the VA shipped out, particularly to veterans in rural areas, to where their mental health care could continue uninterrupted because of the pandemic. And, the VA at that particular time, closed their doors just to make sure that they not only protected the veterans, but protected their staff as well during the early stages of this pandemic to ensure no further spread. So we applaud the VA for being able to move very quickly and get those IT assets out to not only our members, but to all veterans themselves so they can continue their treatment uninterrupted. The other thing is we also we provided testimony at a hearing in June of last year talking about how swiftly VA was able to manage the pandemic and be able to get things out to the veteran community that needed it. So again, hats off to the VA to be able to adapt so quickly and not only take care of just our members, but to be able to take care of all veterans in general when it came down to this particular crisis.
Great. Dr. Armstrong, I think I'll probably want to loop you in on this one. In your role, as far as access to technology and ensuring that the various stakeholders had the ability to receive the care services needed, were there any particular strategies or that were implemented or processes that you underwent to make sure that took place?
Yeah, absolutely. Some of the key ones were that, like Marquis mentioned, we were already disseminating thousands and thousands of tablets with Wi-Fi, as well as laptops, smartphones to veterans as well as VA staff to make sure that everybody had access. Because again, the staff also couldn't come to the hospitals either. So we wanted to make sure everybody had the equipment that they needed. And so we were already doing that, but we just shifted a lot of funding so we can just increase the capacity. So we were able to do that quite well. But honestly, it's not meeting every single need. We find that this is an important service that we're providing. And so we're going to continue investing a lot of money to make sure that every veteran that needs access has that equipment that they need, and also that Wi-Fi that we pay for. So then they're not concerned about data plans and things like that. The other thing is we've created new technologies that didn't exist before that are specific to COVID. So we created the COVID Coach mobile app. Usually, in the government system, I was with the Department of Defense Health Agency for 10 years. And, I've been at the VA central office for 2 years. And usually it takes about 3 years to create a mobile app in the federal government, which might be surprising to people. But we were able to shift really quickly and create this app in mere months. And so things like that, we just shifted quickly. And now we have about 250,000 people that have already downloaded this app and are benefiting and tracking their mental health in that way. Another way that we did that is we have the VA has a text message platform called the Annie app. And so this allows automated text messages to veterans on all kinds of issues they may have: diabetes, hypertension, and also stress and grief. We saw a huge opportunity there, so we shifted quickly and we created 6 different, we call them protocols, but automated messaging services that are specific to COVID. So one is for if a patient is or a veteran is in isolation or quarantine, so they can receive these text messages and then respond back with their symptoms. The great thing about this is then the care team can then log in on their side of Annie and be able to see and track temperature, other kind of symptoms of fatigue, other symptoms of COVID. The other thing is, if somebody is just really concerned about their symptoms, but not in quarantine, we also create a protocol to meet that need as well. We also created 2 protocols to meet the need of all the mental health, kind of the emotional toll that COVID is playing on all of us, all of our patients. And so then they have automated text messages that go to them, and we have about 10,000 veterans already enrolled in this automated service. And really, you just need a flip phone to be able to access that. And so we really have just shifted quickly to provide every opportunity to equip VA staff and also veterans. But I think we still have a long way to go. But, in the 9-10 months of the pandemic, I think we've done a good job. But there's going to be a post-COVID time, and, we're going to be dealing with the mental health effects of this for the next decade. So our work is not over. We are just ramping up our efforts to support veterans.
You're beating me to the next question I'm going to ask, but we'll get there shortly. So, Dr. Warren, I wanted to circle back with you before we left the discussion on equity of access. You talked about a few methods that you've implemented. Are there any other strategies or tools that you want to make sure that we're aware of that you use in order to ensure that the quality of care that reaches the rural areas and some of these underserved communities?
For one thing that we've seen a lot, and I think this is one of the wonderful things about rural communities, is that sometimes we unfortunately take a deficits approach when we look at what's happening in rural. So there's lower broadband access, or they don't have X, or they have fewer providers. But when you start to take an assets-based perspective on rural communities, you can really find some really unique solutions. So some of the things that we've been seeing, and this has rolled out nationwide, but not necessarily the sub-implication, when children started having to go to school at home, there was a huge disruption in mental health access for children, because over half of kids who access mental health services access them in schools, and a third of them only access them in schools. And so there was a giant disruption in mental health access for children. And as schools started rolling out strategies for how to preserve access to their educational continuum, what some communities that I've seen in rural areas do is they realize that also provided the same continuum for mental health services. So for instance, a common strategy I've seen throughout the country is school buses that are Wi-Fi enabled going out into communities to allow children to connect into Wi-Fi in that way so they can access their schooling. But at the same time, that provides them access to the mental health services that they were receiving at school. And so using the school bus as a giant portable Wi-Fi to enable telehealth encounters is something that, looks at what that asset is within the community and how we can deploy it in multiple strategies. So it's supporting the educational continuum and that as well. And the same thing we've also seen with churches. So particularly here in the South, we have a very, very strong connection between rural communities and churches very often being a community hub and access to support. And we've seen a lot of churches doing the same thing of opening up their Wi-Fi where individuals can come and access mental health services through the Wi-Fi of the church. And so it's really helping meet that community need by, creatively deploying the assets that exist. And so I think that's been some really wonderful things to see happening in rural areas, is communities coming together to creatively solve the challenges they're seeing.
Absolutely, that's extremely fascinating. So let's transition over to, on the technology side, adoption. And Dr. Armstrong, I'm going to come back to you to kick this one off. So over the last 9 months, we've seen a spike in telemedicine and telehealth adoption. At the VA, Dr. Armstrong, can you talk to me a bit about some of the trends? And I don't know if you have any metrics that can sort of the measurable impacts. We all intuitively assume that they're a pretty sharp spike, but chat about that a bit.
Yeah, I mean, the really interesting thing about the VA healthcare system is it's one of the largest healthcare systems in the world with over 9 million enrollees. I mean, there's just that when you step back and look at the data, it is really startling to see it all there. And I think it's really an interesting representation of, probably what's happening all around the country, all around the world. But so just for an example, in just the 5 days, January 3rd through 9th, just a couple weeks ago, there was 202,000 virtual visits provided just in those 5 days. And so this is an over 1,700% increase from the previous year. I mean, it really blows your mind, right? And also we look back, now that we've wrapped up fiscal year 20, now that we're, into the second quarter of fiscal year 21, when we look back at the data from FY20, we saw that there was 5.6 million telehealth visits. Now that was only half of that was COVID, right? About half. And that was 5.6 million telehealth visits to over 1.6 million veterans. So this just represents this just huge increase. And also, this isn't just video visits, but also just other things like refilling prescriptions, sending secure messages. Just from January 10th through 16th, just those 5 days, there was veterans sent over 350,000 secure messages to their providers. So veterans need access to these resources. They use these resources. And so we just want to make sure. But then on the other hand, so My Healthy Vet, for example, is the VA's patient portal and provides access to refilling prescriptions, secure messaging, downloading all your health records, which is really, really important if you're receiving care outside of the VA as well, so you can have some kind of interoperability. There's only, out of the over 9 million veterans that are enrolled in VA services, only about half have the right logon credentials to be able to get to My Healthy Vet. And so a big push when it comes to adoption for us is making that an easier process for them, making sure that they don't have to, before they had to come into the VA to kind of authenticate who they were. And we say, you know what, this is just a blockage in the system and it's unnecessary. And so let's think of new policies, new ways of approaching this to provide access to all veterans so they can get these really important services. They all need to get their prescriptions in secure message and also schedule appointments. So.
Wonderful. That brings me to a question for Marquis. So to Dr. Armstrong's point about adoption and some of the potential challenges with your stakeholder group, have there been issues that could be improved upon in terms of how to make it easier for your constituents to leverage and utilize some of the telemedicine benefits and telemental health services that we could highlight?
Yes, David, thank you for the question. As Dr. Armstrong has highlighted, the VA has done, and I've mentioned earlier, the VA has done an amazing job over the last 9 months with being able to convert from a majority of its veterans coming into brick and mortar VA facilities to being able to use technology to help them continue with their care and services that they need, like refilling prescriptions or seeing their primary care provider, or also continuing their mental health appointments. Some of the challenges, though, have been with the technology that is sent out, the iPads and the smartphones. A lot of the population of the veteran community is a little bit older, so some of them are not very technologically savvy, so to speak. So one of the challenges that we would like to see is, making things just a little bit simpler when it comes down to the instructions. That way, an older veteran that's, either Vietnam or Korean era will be able to, when they cut that iPad on, there's a very simple step-by-step guide to say, okay, push this button here, answer this question here, or being able to log on to My Healthy Vet with just a few simple pushes of just a few simple buttons on a touchscreen. That way, as Dr. Armstrong mentioned just a moment ago, they'll have access to their electronic health record, or they can easily push a couple buttons to refill their prescriptions when necessary. Because a lot of that technology, even though it's simple for us because we use it every day, but when you put it into the hands of someone who's not very familiar with it, you have to make sure that there are very easy to follow training steps to go along with that. That way, that veteran or their caregiver or someone who's there to provide for them will be able to guide them through that big technological river to make sure that they can get what they need.
Makes perfect sense. I imagine, Dr. Warren, there's a subset of your care group that would follow along that same those same lines in terms of the simplicity of the technology, helping with their ability to actually utilize the services that are offered.
It does. It's really highlighted sort of a third literacy that we always knew existed, but this has really brought it out. We talk about overall literacy and we talk about health literacy, but now technological literacy really is factoring in really strong ways into how individuals are able to receive their health care. And so I think we're all sort of having to shift, exactly like both the other panelists mentioned, of how do we ensure that we are meeting people. We've gotten used to approaching it from a literacy. More recently, we started thinking about health literacy and understanding how we need to convey health information. But now exactly this point comes to a head of how do we even get people to know how to utilize technology that so many of us take for granted that people know how to use. And so taking that approach, I think, has been really important. At the same time, though, what we've been seeing in terms of adoption is it really is almost a foot in the door effect. So people that we have been trying to engage in telehealth and saying, we can get access, we can get you to a postpartum depression specialist through this technology, but people are resistant. Now that virtually all of us have had telehealth encounters, I hadn't had one before the pandemic, and now I have, almost everyone has had one now, and it sort of removes that, I don't want to say fear, but just this, it's a huge unknown of how that even works. Because, when you really think about it, telehealth does break down virtually everything we know about how a medical encounter or even a mental health encounter occurs. It's that in-person connection. They're able to examine you. And so it's a little strange, but once you get used to it, you're able to then realize how convenient it is, how much it saves time, how much it can expand access for those who have access to the technology necessary. But that's been another interesting thing that we've seen is this foot in the door where once someone starts using it, then we're seeing actually better retention into programs and better follow through and better adherence to recommendations because they're able to realize how easy it is now to access once they have that initial encounter.
Absolutely. That brings to mind, imagining a post-COVID world and what the future would look like. So, Dr. Armstrong, I'd like to ask you, in this post-COVID utopia, how do we continue to engage in telehealth and mental health care sessions? What do we want to happen? What do we think will happen?
Yeah, so I think there's a couple things. First of all, I think people have been able to shift quickly. I think people were more staff, so healthcare staff and patients, we see that they're much more adaptable than we thought we all could be, right? We've had to do these things and, for the most part, it's working, right? So what I'd like to see in post-COVID, though, is continued increased adoption. I want to make this the new norm. I want there to be options for patients. It really is about meeting the patient wherever they are at. And if they want to receive care at their home, then hopefully now we've kind of reduced the stigma around that in terms of staff thinking, well, that's not the same. It's not going to be the same level of care. Now we see we can actually do quite a bit and the patients really like it. So I would really like to see an increased adoption, but also what we saw with the pandemic, everyone had to shift really quickly. So a lot of things happened and a lot of people weren't adequate, like staff members were maybe not adequately trained in all the competencies necessary in the integration of telehealth, mobile health, integration of sensors, wearables, remote patient monitoring. Those competencies exist. And we're working hard. A big part of what I'm doing is creating curricula so that we can push out to staff and make sure that everybody is adequately trained. That's not something we could have been thinking about in, March, April, May of last year. We really were just scrambling to get everybody everything they needed. But now moving forward, I think making sure that everybody has the right training and then that scrambled approach isn't the norm. I want it to be providing the highest level of care possible through whatever modality patients choose.
That sounds wonderful. Marquis, in terms of what you would like to see in the future for your constituency group, how would you like for their support to either be enhanced or continue in the post-COVID environment?
Yes, as Dr. Armstrong mentioned just a moment ago, it's good on both sides to where the VA personnel and medical staff receive that training. As she mentioned, things changed very rapidly in the past 9 to 10 months. And not only was VA staff scrambling, but the veterans themselves were scrambling because they were worried about, how is my care going to continue? Will I be able to still have my primary care physician see me? Will I be able to still go and see my specialist for, in this particular case, we're talking about mental health. So will I be able to go and see my mental health doctor? Will I continue with either group or individual therapy? So there were a lot of questions that veterans had themselves of how would their care continue during the course of this pandemic. And the VA has done a wonderful job of being able to adapt very quickly to be able to accommodate. And yes, there may have been a few missteps and a few people that have fallen through the cracks, but the VA has done a commendable job in regrouping and making sure that no one is left without, prescription drug refills, primary care physician visits, and their mental health visits. So in the post-COVID world, a lot of veterans still would like to physically go into a VA medical facility, but for those that are comfortable with the technology, yes, please continue to allow them to use it and utilize it. And like I said before, just make sure that it's user-friendly to them, that they don't get left behind or they don't do something that leaves them out of receiving the services that they need. And also when the VA partners with the community, making sure that the community partners that they utilize, that they are trained and understand that you all, the community partners, need to furnish care at the same level that a veteran would be able to receive at a VA medical facility, and make sure that they have the training necessary to understand that, veterans are a very unique group of people and they have very specialized needs. So you can't treat them like you treat regular civilians, especially when it comes down to mental health care. So you have to be very well trained to understand the needs of veterans, especially those that are receiving mental health care. So in a post-COVID world, yes, training is going to be very key. As these past 9 or 10 months have shown us, a lot has to be done and a lot has been done to improve the VA and the way it delivers its health care. But we need to continue that to make sure that it's still successful.
Thank you for that. Dr. Warren, your thoughts on a post-COVID environment in the rural areas that you support?
A lot of the things that we've been talking about recently are looking into that post-COVID world and what we actually want to carry forward. So many of us are thinking of the things we want to leave behind, but especially for rural communities, the changes that we've seen in insurance policy that have been put forward through emergency action orders, if they expire after the pandemic, then all this access that's been expanded within rural communities will be lost. And so it's going to be really important for us to continue to push for the importance of permanently codifying a lot of these changes. So for instance, we know the feds changed the regulations regarding home-based telemental health services that previously, you had to have very specific combination of factors to be able to qualify to receive those services at home under Medicare. And because of the pandemic, they recognized, okay, we need to do this at home because you can't access it in person where you typically would have. Well, in rural, what this has allowed us to do is access care where it was never accessible before. And so if that home-based telehealth coverage expires, it's not that these individuals can go back to an in-person provider. They didn't have an in-person provider. And so really looking at how the permanent codification of some of these changes comes into play for rural equity is going to be really, really important. Another aspect that we're all hoping that we can get some energy around kind of capitalizes on what Marquis and Dr. Armstrong have mentioned of how we can expand our definition of home-based durable medical equipment to potentially include technology access, because we can send someone a wheelchair, we can send someone a Holter monitor, but we can't send them an iPad to access mental health services. And if we can somehow look at the regulation environment to see how we can make actual technology, for the fundamental encounter part of durable medical equipment or some other coded legislation, then we can really make these expansions permanent.
Those are great insights, Dr. Warren. Thank you for that. Well, we're approaching the end of this panel. I wanted to thank all of you, Dr. Armstrong, Marquis, and Dr. Warren, for your insights and all the work that you're doing. Up next, we will transition over to a digital transformation discussion with the next one. Thank you.